If we had disagreement about around a 1 or a 2, that makes all the difference. 1 is considered remission, a score of 2 or greater is considered recurrence. That would be a big deal. So what we did is we split out the scores. Again, yellow's infliximab, red's placebo. Most of the infliximab-treated patients had no active ulcers or inflammation at all. They were completely normal. Whereas over 50% of the patients in the placebo arm had very high rates of endoscopic recurrence, not just a 2, but a 3 or a 4. So we did see a split between the group, and it seemed that the placebo-treated patients, and when I say placebo-treated, many of these patients in the 3 and 4 were on weight-based doses of azathioprine and 6-MP. So they had been on that prior to the study and continued on that treatment postoperatively. We looked at clinical recurrence, which again, I'm not sure is the best parameter to look at postoperatively, but we did include these data. About 40% of the patients in the placebo group did have symptoms that would be considered clinical recurrence, whereas none of the patients in the infliximab group had what we would consider a clinical recurrence. So conclusions from this small pilot data were that at least from the 24 patients is that infliximab seemed to prevent endoscopic recurrence at a year, and we didn't see any complications in giving a first dose of infliximab within 4 weeks of the study. Well, what are some other data? Obviously, the PREVENT study is underway, and the question comes up, well, this is great. That's only 24 patients, though. We cannot make much out of that study. So there have unfortunately only been 2 other very small studies. So I can't stand up here before you and say that we have 600 patients who we know what these data showed. Hopefully the PREVENT study will show that. However, we do have an open label study by Sorrentino looking at infliximab, and then there is one adalimumab study that, as far as I know, is still in abstract form. I haven't seen the publication yet. And if you look at our studies in the middle, placebo versus anti-TNF, the Sorrentino study combined methotrexate with infliximab and looked at these patients out to 2 years and actually found that 0% of the patients had an endoscopic recurrence 2 years later. The adalimumab study on the bottom showed an endoscopic recurrence rate, which was similar to what we found. About 10% of the patients had an endoscopic recurrence. So at least on 3 very small studies, you're seeing some trends. I would call this still signals. I don't know that we can say enough yet without pivotal data, but at least there seemed to be some consistency and trends between these small studies. So if we now include infliximab, at least based on the data we have so far, the question is this something that we should be looking at as a postoperative prevention model? So where are we now? I think in a clinically practical standpoint, we do need to consider risk factors for recurrence postoperatively in a management strategy in terms of how we treat these patients postoperatively. So certain risk factors that have been associated with recurrence of Crohn's after surgery include early age of surgery, short time to first surgery, not only having just ileal disease, but colonic disease. Those are all pretty good as far as predictors, and this has been published by several groups. The ones that I think most agree on based on the data is that active cigarette smoking after surgery portends a very high risk of recurrence. Penetrating or fistulizing disease, so the patient you see with an abscess or a perforation or a fistula at the time of surgery. And I'm not saying a fistula just because there's a high pressure zone above a stricture. I mean truly penetrating disease. These are very high risk for recurrence, and there have been several publications on this. And those patients who are on their 2nd, 3rd, 4th, 5th surgery, those with multiple prior resections, those are obviously high risk for recurrence patients. So again, what's my treatment algorithm? And in no way would I say anti-TNF is at the bottom of each of these. That's absolutely not what I'm doing in my clinical practice. What I am doing in my practice is for those patients with a low risk for recurrence. So who are those? And probably like you, these are patients we don't see very much because they're not coming to a tertiary care center. These are patients who may have had 15, 20 years of disease, who come in for their first surgery for a 6-centimeter stricture with no inflammation at all at the time of surgery, who have not received medicines. I wouldn't treat those patients at all. I'd leave them alone. But I would do a colonoscopy 6 months to a year after surgery, and if there is significant endoscopic recurrence, despite them feeling well, having clinically silent disease, then I would escalate treatment to at least an immunomodulator, and depending on the severity of recurrence, possibly an anti-TNF. So this is a very rare group, but this would be a group I would not do anything for. I think the more common group, and this is still a group that I would look at immunomodulators and possibly combine them with an antibiotic like metronidazole, are the patients who've had relatively short time between diagnosis and surgery. So arbitrarily less than 10 years. So they haven't had 20 years of disease, less than 10 years of disease, who are coming in for a resection where the surgeon's seen active inflammation and they've had a stricture, they've had stenosis for which they're coming to surgery. I do think, based on the DeHaan's data, that if you combine an antibiotic with azathioprine, the rates of recurrence are lower. The problem with that is the tolerance of the antibiotic is very poor, meaning that if you have a patient that can take 1 to 2 grams of metronidazole a day for a year, you'll probably see some of the lowest recurrences. At least in Pittsburgh, and I don't know if alcohol is more prevalent, but I cannot get my patients to take metronidazole more than 2 weeks, let alone for 3 months to a year. Ornitazole actually is an interesting alternative, although the rates of tolerance with ornitazole are quite high. Hans Herfath is actually now looking at ciprofloxacin in the postoperative model, and that hopefully those data are wrapping up and we'll have some idea as far as that antibiotic strategy. But clearly, combining an antibiotic with an immunomodulator may make sense.
Miguel, I think they got smarter about metronidazole in their most recent combo study. They went with metronidazole 250 TID.
Right, they went with a smaller dose.
Seems to be more tolerable.
It was more tolerable. The interesting thing, though, when you look at from a post-op recurrence, the rates of recurrence seem to be a little bit higher. And this is actually with one of our microbiome people in Pittsburgh. We were talking about antibiotic strategies and different ways of changing the intestinal flora, because that's really what we're looking to target. And there may be some even non-antibiotic modalities coming out down the line. But I agree, obviously using the lower doses are more tolerable.
I don't think that tolerance is alcohol either. I think that alcohol problem with metronidazole is way overblown.
Right.
I actually think it's just an intolerance to the drug, even in patients who don't drink at all. But it's incredibly common. But it's really not an alcohol issue. It's really just it's a tough drug to take.
Right. That was my tongue-in-cheek stab at Pittsburgh. But you're right. It's a hard medicine for young, healthy people to take, and I had to take it for a few days one time, and it is. The taste is bad. You get nausea. I mean, there's a lot of problems. So imagine having to take that for a long time. That can be very difficult.